Hi, my name is Luis Alvarez. I'm interested in becoming a registered respiratory therapist. Today I've been given permission to job shadow a lead RRT at Ball State Medical Center. I'm so excited.
Hey Luis, I'm Jeff.
Nice to meet you.
Likewise. Good morning. So, I'm Jeff, and I'll be mentoring you today. I just received an order from a pulmonologist to evaluate a patient for potential discharge. Since you've completed the HIPAA training and have satisfied the requirements for the Human Resources Department, you've been approved for the exam to examine the patient information with me. So let's review the patient's electronic medical record.
Okay.
All right. So I always begin by reviewing admission information. It contains a SOAP and gives me a lot of information about the patient. The letter SOAP represents subjective, objective, assessment, and plan. So it's used for general admissions so they know how to evaluate the patient. So first off, subjective is things, how the patient says that they feel, like I don't feel good or I can't breathe, something like that. The next one, objective. Things that you can actually obtain. Vitals, heart rate, anything like that, their general appearance, any laboratory tests or studies that you can actually pull up, like chest x-rays, EKGs, stuff like that. Also, thirdly, assessment. These are things that you've seen from the patient, like bronchospasms, pulmonary hyperinflation, chronic ventilatory failure with moderate to severe hypoxemia. So, and lastly, plan. P for plan. We want to begin, this is what we want to do. After we've done our general assessment, now this is what we want to do to the patient. So we'll begin protocols for ventilator management, oxygen therapy, aerosol therapy, or if we need to, we can initiate non-invasive positive pressure ventilation. Okay. So when Miss Tubbs got here, she appeared in a moderate amount of distress. We looked at her vital signs after she had been on the BiPAP for about 30 minutes. I'll explain the non-invasive positive pressure ventilation to you a little bit later. So here I have some of her PFT results from clinical visit she had earlier this month. So right here, you have the values that we measured, the FVC, FEV1, FEV1, and over the FVC, which is how you just determine whether or not she has an obstructive or restrictive. So we give a predicted first for each one, and then we'll do a pre-bronchodilator for each one, and then we'll give her the bronchodilator, and then test them again. So there's the results for that. But we'll go more in depth into this later, okay? We know about GOLD?
Gold jewelry?
Not exactly. GOLD is an acronym for Global Initiative for Chronic Obstructive Lung Disease. There are many board of directors and doctors that make up this company, this network from many places around the world, expanding all the way to Japan. The purpose of the network is to raise awareness for COPD and to improve prevention and treatment for COPD. Let's look at the pocket guide.
Okay.
This is the pocket guide that I have from them. As you can see, it was updated in 2015, so it's fairly recent.
Okay.
So everything in here is pretty well up to date.
Okay. So I have a question. One of my family members has COPD, and he has trouble breathing.
Okay.
How could gold help?
Well, good question. COPD, chronic obstructive pulmonary disease, is a major cause of morbidity and mortality throughout the world. Much has been learned about COPD since the Global Initiative for Chronic Obstructive Lung Disease issued its first report, Global Strategy for Diagnosis, Management, and Prevention of COPD in 2001. So treatment of COPD is now aimed at immediately relieving and reducing the impact of symptoms, as well as reducing the risk of future adverse health events such as exacerbations. These dual goals emphasize the need for clinicians to maintain a focus on both the short and long-term impact of COPD on their patients. So a framework for the COPD management that matches individual assessment of the disease to these treatment objectives will better meet each patient's needs.
Okay.
Several educational tools and publications oriented around this approach to COPD are available at goldcopd.org and can be adapted to local healthcare systems and resources.
Okay. So what is COPD exactly?
COPD, another good question. So COPD stands for chronic obstructive pulmonary disease, like I said. It's a common preventable and treatable disease. It's characterized by persistent airflow limitation that is usually progressive and associated with an enhanced chronic inflammatory response in the airways and along to noxious particles or gases. Exacerbations and comorbidities contribute to the overall severity in individual patients. This definition does not use the term chronic bronchitis or emphysema and excludes asthma, which is a reversible airflow limitation.
Okay.
Some of the symptoms that you include with this is dyspnea, chronic cough, chronic sputum production, just to name a few. So episodes of acute worsening, or these symptoms, or as we call exacerbations, often occur. So spirometry is required to make a clinical diagnosis of COPD, which we do fairly often. The presence of a post-bronchodilator, FEV1 over the FVC of less than 0.70, confirms the presence of persistent airflow limitation and thus COPD.
And that's what you were showing me on that chart.
Exactly.
Okay.
About Miss Tubbs, right?
So what causes COPD?
Good question. So some of the causes, the worldwide is the most commonly encountered risk factor for COPD is tobacco smoking. Everybody loves to smoke, so just can't get them to quit. Outdoor, so not only tobacco smoking, but outdoor, occupational, and indoor pollution, the latter resulting from burning of biomass fuels and other major COPD risk factors. Non-smokers may also develop COPD.
Mm-hmm.
Most people don't know that. So the genetic risk factor that is documented a severe hereditary deficiency of alpha-1 antitrypsin. It provides a model for how other genetic risk factors are thought to contribute to COPD. The COPD risk is related to the total burden in inhaled particles a person encounters over their lifetime. So things like tobacco smoke, including cigarettes, pipes, cigars, and other types of tobacco, is smoking popular in many countries, as well as environmental tobacco smoke. So another one was indoor air pollution from biomass fuel used for cooking, heating, and of course in poorly vented dwellings that it builds up and you're constantly breathing it in. So a risk factor that particularly affects women in developing countries. Another would be occupational dust and chemicals like vapors, irritants, fumes, when the exposures are sufficiently intense or prolonged. Outdoor air pollution also contributes to the lungs' total burden of inhaled particles, although it appears to have a relatively small effect in causing the COPD itself. In addition, any factor that affects lung growth during gestation and childhood, like low birth weight, respiratory infections, etc.,
Yeah.
has the potential to increase an individual's risk of developing the COPD.
Okay. Well, I wonder if Mrs. Tubbs has ever smoked tobacco.
Earlier I mentioned that Mrs. Tubbs is well known in our department. She's been a patient here several times over the past few years. She's a very heavy smoker and typically smokes about, she says, 2 packs per day and has been doing so for 20 years now. So if we do the math, that gives her 40-pack-year history of smoking. Part of our departmental smoking cessation protocol is to identify all smokers and encourage them to quit. We've tried to counsel her many times about smoking cessation during our hospital visit, but she is just not very receptive to the idea and is not for it. She just loves her smoking. So since I'm also the department's tobacco cessation counselor, I'll just review the 5 R's of motivational intervention with her today.
I've heard about the 5 A's of smoking prevention, but not the 5 R's.
Really? Okay.
Yeah.
So let me give you a quick rundown. So we use a clinical guideline, clinical practice guideline for the treating tobacco use. Independence 2000. It was updated. So it recommends using the 5 R's of motivational for patient use, or for patients who are unwilling to make quit smoking attempt.
Okay.
So 5 R's, the first one is relevance. It's about encouraging the patient to quit smoking. Ultimately, we want them to quit. I mean, that's the goal. That reduces their COPD exacerbations and the progression of their disease itself. Secondly is risk, is about identifying the potential negative consequences of tobacco smoke. What can this do to you? Most people think, oh, I can do it, I've only done it for so long, I'm good. No, no matter each one that you smoke, it just makes things 100 times worse. Thirdly is reward, is where you will ask the patient to identify potential benefits of stopping tobacco use, make them aware of it. So if they quit smoking, they'll know the benefits to quit smoking. Maybe that will essentially encourage them to stop by knowing that. Fourthly, we want roadblock. You ask the patient to identify barriers or impedance for them to quitting. So why can they not stop? I mean, you want to know what the barrier is so that maybe you can help them with that. Exactly. Or maybe there's something you can do to help them. So lastly, repetition is where this should be repetitive every time an unmotivated patient visit, every time the patient visits the clinical setting. So every time they come in, do the same thing every time. I mean, eventually they'll get sick of hearing it, but it's repetition. The more you hear it, maybe they'll start catching on and it'll actually hit to them. So if a patient desires to quit and would like to try nicotine replacement therapy, I can recommend several products, such as nicotine gum, nicotine lozenges, which are almost like little hard candies, kind of like a cough drop, but it's for smoking. Right, you just suck on it. There's a nicotine nasal spray, a nicotine transdermal patch, a sublingual nicotine tablet, or a nicotine inhaler. So if a pharmacological agent is preferred, bupropion SR, varenicline, or nortriptyline could be also suggested.
Wow, I didn't realize RTs also provide smoking cessation counseling. I can't wait to observe your reaction with Mrs. Tubbs. Can I ask you another question?
Absolutely, I love that, answering questions, and I'm a teacher at heart. I love being a respiratory therapist, and it's making my day to be able to share everything I know with you.
That's nice. Thank you.
Yeah.
So how is COPD diagnosed?
Good question. It's a clinical diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough, or sputum production, and a history of exposure to risk factors for the disease. Consider COPD and perform spirometry if any of these indicators are present in individuals over the age of 40. These factors are diagnostic themselves, but the presence of multiple key indicators increase the probability of diagnosis of COPD. Spirometry is required to establish a diagnosis of COPD. And then I have a few terms over here that we'd like to review with you. Maybe it'll help stick it a little bit better. So dyspnea is a progressive or worsens over time, having trouble breathing. Characteristically worse with exercise, and it can be persistent. Chronic cough may be intermittent and may be unproductive, so they can cough all they want, but nothing ever comes up. They can have chronic sputum production, which is the other end of it. Any pattern of chronic sputum production may indicate a COPD. They may have a history of exposure to risk factors. So like we talked about earlier, tobacco smoke, which including popular local preparations, smoke from home cooking and heating fuels, occupational dust and chemicals, and then also if they simply have a history of COPD. So spirometry is required to make a clinical diagnosis of COPD. The presence of a post-bronchodilator, FEV1 and FVC less than 70, confers the presence of persistent airflow limitations and thus of COPD. All healthcare workers who care for COPD patients should have access to a spirometer. So do you remember Mrs. Stubbs' post-bronchodilator FEV1 that we talked about?
No, I don't know how you remember so much. It's information overload and can be overwhelming.
I definitely understand. I know how you feel. I studied long and hard when I was a student of the Ball State Respiratory Care Program. Pulmonary function testing was certainly not my favorite topic, but once I got hired, I actually began obtaining and assessing spirometry values on a regular basis, and it began to really stick in my brain. You'll see what I mean one day.
Thanks for positive understanding. My father had a spirometry test before. Can you explain why it's an important assessment tool for COPD patients?
Yeah, absolutely. Spirometry is required to make a clinical diagnosis of COPD and should be available to all healthcare professionals who work with COPD patients. So what is spirometry? It's a simple test to measure the amount of air a person can breathe out and the amount of time it takes to do so.
How is exhale gas measured?
It's measured with a spirometer, which is a device used to measure how effectively and how quickly the lungs can be emptied out.
Does it show exhale volume?
It does actually by a spirogram, which is a volume time curve. So an FVC, which is a forced vital capacity, is the maximum volume of air that can be exhaled during a forced maneuver. There is an FEV1, which is a forced expiratory volume in 1 second, which is the amount of volume expired in the first second of maximal expiration after a maximal inspiration. So it's a measure of how quickly the lungs can be emptied out. Thirdly is an FEV1 over the FVC. So the FEV1 expressed as a proportion of the FVC gives a clinically useful index of airflow limitations. So, go ahead.
That's so confusing. I still don't understand how this relates to gold.
So the ratio FEV1 FVC is between 0.70 and 0.8 in a normal adult. A value less than 0.7 indicates airflow limitations and thus COPD. So I'm gonna write the basics for these. Alright, so according to the gold standard, there's gold 1. Oops, sorry. Gold 1. I'm going to show you where this Cubs falls in the middle of all this. So you have gold 1 being mild, moderate, severe, very severe. And then FEV1 likely seen. Or equal to 80% of the predicted. So for our model, it would be FEV equal 50%, less than or equal to 1, less than 80% of the predicted. Then for severe, it would be 30%. FEV1. Or less than 50%. And for very severe, we have an FEV1 that is less than 30% of the predicted. So, this is Tubbs' most recent post-bronchodilator for FEV1 and FVC is 65%. So, by using this evidence-based gold strategies, we can classify the severity of Mrs. Tubbs' airflow limitations. So, if she was at 65%, in this case, say between the 50 and the 80, so hers, she would have a gold standard 2 of moderate at 60%. 65, sorry.
So low classification is a simple way to categorize how severe a COPD patient airflow is being limited based on post-bronchodilator FEV1 values. Goal 1 indicates that the most ability to blow out air. Goal 4 is the worst classification, and it means that the patient has the least ability to blow out the air.
Yeah, that's correct.
Okay. So does every adult have the same predicted FEV1?
No, the FEV1 is influenced by the age, sex, height, and ethnicity, and that's considered as a percentage of the predicted normal value. There is a vast literature on normal values, and those appropriate for local populations should be used. So, why do spirometry for COPD patients? So first off, spirometry is needed to make a clinical diagnosis of COPD like we mentioned before. Together with the presence of symptoms, spirometry helps gauge COPD severity and can be a guide to specific treatment steps. Thirdly, a normal value of spirometry effectively excludes the diagnosis of clinically relevant COPD. The lower the percentage predicted FEV1, the worse the subsequent prognosis of this. So I'm going to draw the and I'll draw the spirometry for it. Over here, where normal. So over here on this side, I'll do volume. Meters. We'll have and then the bottom will have the time in seconds. 1, 2, 5. So for her, between a 4 and a 1, so first, a normal person, theirs would look something similar to this. Come up and come over like this.
Oh, okay.
So between here and here is your FEV1, and then between here and here will be your FVC. So your FEV1 in this case equals 4 liters. Her forced vital capacity equals 5 liters, as evidenced by that. And then the FEV1 over her FVC, once calculated, would be 0.8. So this would be, like I said, for a normal one, and then for a mild to a moderate COPD patient like Mrs. Tubbs, will be over here. So again, we got the volume. This down here again would be time in seconds. So for a mild or moderate, you would see a spirometry test similar to something like this. So that's something about what hers would look like.
Because
So
they have a hard time getting all the air out.
absolutely. So their FEV1 would essentially be in this category right here, and then the forced vital capacity would be somewhere in this category, right to there. So again, FEV1 equal to about 1.8 liters. FVC equal to 3.2 liters. Forced vital capacity will be equivalent to 0.56. So obviously you can see a huge difference. Hers is a lot smaller than somebody normal. So
Yeah.
of course this would certainly indicate, because we go by the FEV1 and the forced vital capacity, the percentage, which would determine, of course, that she has an obstructive lung disease.
Okay.
All right.
That makes me understand it a little bit better.
Good. So, of course, after showing me that, the FEV1 declines over time, and usually faster in a COPD patient than in a healthy patient, or in healthy subjects. So spirometry can be used to monitor disease progression, but to be reliable, the intervals between the measurements must be at least 12 months.
How do you perform spirometry?
I'm glad you asked. Mrs. Tubbs is eating breakfast right now, so I have time to show you how to do a real demonstration.
Will it hurt?
Absolutely not. I'll talk you through each step, and then we can look at your results when we're done. And so here's one of the bedside spirometers that I talked about that you're going to do. So first off, you can see right here is what I'm going to be looking at to get your numbers and everything. So first off, you want a couple instructions. You want to get a good seal with your mouth and your lips around here for your teeth. If you need nose clips, we can get some. I have some for you if you need them. So you seal your lips around the mouthpiece. You'll force all the air out. You'll start off with a couple good normal breaths, and then I'll instruct you to take a big deep breath in, and then force all the air out. And then just keep going and going and going, and then I'll have you take another big deep breath in. Okay?
Okay.
Got it?
Got it. Alright.
Alright, so normal breaths. Big deep breath in. Blow, blow, blow. Keep blowing, keep blowing, keep blowing, keep blowing, keep blowing, keep blowing. Big deep breath in. Good. Well done. Relax. Don't let it in front. That's awesome.
Is it good?
Can always be better. We do a couple more. Alright, so start breathing normally. Good seal. Whenever you're ready, after exhalation, take a big deep breath in. Blow it out. Hard, hard. Blow, 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 blow. Blow. Keep blowing. Big deep breath in. Good. There you go. Really good. Alright, you're good. Alright. Well done. Take a breather. Good. Big deep breath in. Blow, 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 blow. Keep blowing, keep blowing, keep blowing, keep blowing. Big deep breath in. Excellent. That was best one. Alright. Woo. Feel alright?
Yeah.
That's good. So right here you can see your numbers. So it's actually not too bad.
Okay. So, now I understand a bit more how spirometry is a valuable tool used in diagnosis of COPD. How often is it checked?
It is assessed on an as-need basis. The goals of COPD assessment are to determine the severity of the disease, its impact on the patient's health status, and the risk of future events, exacerbations, hospital admissions, or death, in order to guide the therapy. So we'll do the assess the following aspects of the disease separately, such as symptoms, degree of airflow limitations using the spirometry, risk of exacerbations, and comorbidities. So symptoms are assessed by validated questionnaires such as the COPD assessment test, or the CAT, or the clinical COPD questionnaire, the CCQ. They're recommended for a comprehensive assessment of symptoms. The Modified British Medical Research Council, or the MMRC scale provided only an assessment of the breathlessness. So I'm going to show you, before we start talking about the questionnaire, I'm going to show you this questionnaire. You can look over it while I tell you more about it. So risk of exacerbations are assessed, and an exacerbation is defined as an acute event characterized by a worsening of the patient's respiratory system that is beyond normal day-to-day variations and leads to a change in medications. The best predictor of having frequent exacerbations, which is characterized by 2 or more per year, is a history of previous treated events. The risk of exacerbations also increases as the airflow limitation worsens. Hospitalized for a COPD exacerbations is associated with a poor prognosis with increased risk of death. Cardiovascular disease, osteoporosis, depression, and anxiety, skeletal muscle dysfunction, metabolic syndrome, and lung cancer, among lots of other diseases, occur frequently in COPD patients. These comorbid conditions may influence mortality and hospitalizations and should be looked at routinely and treated appropriately.
Smoking cessation is an important part of COPD management. Are there additional management tools for patients with COPD?
Yeah, actually, and I'll review the management of stable COPD with you. So once COPD has been diagnosed, effective management should be based on individual assessment of current symptoms and future risks. So to reduce some of those symptoms, we can relieve the symptoms, improve exercise tolerance, improve health status, and we can reduce the risk by preventing disease progression, prevent and treat exacerbations, and reduce the mortality. So these goals should be reached with a minimal side effects from the treatment. A particular challenge in COPD patients, though, because they commonly have comorbidities that also need to be carefully identified and treated. So some of the non-pharmacological management of COPD is categorized according to individualized assessment of symptoms and exacerbation risk. Mrs. Stubbs is in patient group B. Essential, recommended, and local guidelines for her include smoking cessation, which can include pharmacological treatment, pulmonary rehab, physical abilities, and she can get a flu vaccine or a pneumococcal vaccine. So, according to, some of the pharmacological things we can do is, our first drug, we can give her Advair or generic salmeterol and fluticasone, which is a maintenance drug, not a rescue drug. We can give it 1 inhalation twice a day, or if they don't work, we can alternatively give her some albuterol, or other than that, we can give her some theophylline. So pharmacologically, we can give her Advair as a first choice, or even as a second choice, and then alternatively, we can give her some albuterol, or Ventolin, or Proventil as they call it generically, or some theophylline. So, Luis, any questions?
No, you've been very thorough. Thank you so much for helping me learn more about the role of respiratory therapists in smoking cessation and COPD management. I'm looking forward to the rest of the day.
You're welcome.